Woo! Okay. Excellent. All right. Hi, everyone. Folks at home, you can't see us. You can just see the slides. We have a really full house here at Cancer Support Community in Sierra Madre. Thank you, everyone, for joining us. We are recording. This is our first attempt at doing the hybrid thing, but like big and large. And we're excited about it. So thank you, Dr. Goldsmith, for being our little guinea pig here.
No pressure.
So I'm going to be monitoring the chat and all that good stuff from my computer in my office. So I'll double check when I get there that these folks can actually hear me. So we'll get all of them on board. Thank you all so much for joining us and for even delaying support groups to be here with us. We're so excited to see you. We have Dr. Goldsmith here to talk to us about harnessing the power of the immune system. How many people signed up for this because the title just sounded so great? Absolutely. We want to harness the power of our immune system. Absolutely. And I must say, just personally, I've got an intro, but I would just like to say that Dr. Goldsmith has been so responsive, and he's just one of those physicians that really cares about patients and being in the community and giving this talk. So every time I emailed him, he emails right back. So we're just so excited anytime we can have just such an amazing physician come in, tell us about their work, educate us so we can feel more empowered. So if it's all right with you, I'm actually not going to do this introduction. You're welcome to share all your amazing credentials, but just thank you so much and welcome to Cancer Support Community. Please join me.
Yeah, I really appreciate the invitation to speak to you all. I didn't realize I was going to be the guinea pig before your setup, so I'm trying to make sure that it works. So I'm actually at the bottom of the food chain in the myeloma division at City of Hope. I am a malignant hematologist and cellular therapy specialist and bone marrow or stem cell transplant specialist. But I wanted to talk today in kind of general terms about how the field of oncology has shifted just over the past really 10 to 15 years, as we've started to learn that really cancer, all different cancers, they kind of develop and evolve in a way that they learn to evade the immune system. So it used to be that we would use chemotherapies to harm the cancer, to kill the cancer, but then it would also, the byproduct was that it would also harm the immune system. Now we started to realize that cancers have these unique mechanisms of getting around the immune system. And now we've been working in many different ways to retrain the immune system to find the cancer, to kill it. And we've seen some amazing progress based on a lot of this research. So I'm going to present to you the different types of immune therapies, and I'll kind of go through my outline here. Let's see. So we'll talk about why we are now trying to, I figured that out. Why we're using the immune system to fight cancer, kind of the ways that cancer gets around it. Some examples of the immune therapies and cellular therapies that we're now using, first starting in blood cancers and hematologic malignancies, but now moving into all different types, both in clinic and investigationally. We'll talk about stem cell transplantation, which was actually kind of the original cellular therapy, indications, what the different types are, and then how they use the immune system. We'll go through a couple of case scenarios from my own experience with my patients. Like I said, I treat predominantly multiple myeloma, but it has relevance to all the different types of immune therapies that we're using. And then if you all have any questions, feel free to ask. I think we're saving it toward the end, but if you have a burning question in the middle that you just can't wait, I'm more than happy to answer it. So just taking an example from the progress that has been made with the cancer that I treat, and this is reflected in all other cancers, the improvements in patient survival and their time to relapse has been increasing almost linearly, but it's now moving in a way that's going to probably be exponential. And this graph just shows the developments of the past 50 years in the treatment of multiple myeloma, with the bolded treatments actually the immune therapies that have been developed. So it started out with all we had were steroids and then chemotherapies, but then we started to identify that myeloma, as well as other cancers, really is a function of the immune system not working. And so we're now finding ways to retrain that and combat myeloma and other cancers. And so what I expect to see is that the patient survival and how things go is going to increase almost straight up from the point that we're at now. So memorize this diagram because it will be on the quiz later. But this schematic, I mean, it's drawn from like a cancer review of how the cancers evade the immune system, but there's all of this complexity where the cancer cell has these things on its surface and it kind of blocks the signals that would normally trigger the immune system and actually eradicate it. So that's one of the first steps in how cancers are able to evade it. And once we started to learn that, we realized that we could actually interrupt those things. We could block the little proteins that these cancers were expressing and really kind of take the brakes off the immune system, the brakes that the cancer cells were actually putting on it. So as kind of a little bit of a review, conventional chemotherapy that we've been used to for so long actually functions to kill cells that more rapidly divide. What it does is it interrupts the ability of the cells to split, and so cells that split more rapidly are more susceptible to it. So that would include things like cancer, but also other cells such as the GI tract and the immune system. And so we started to learn that these weren't as effective alone. The researchers over the past 20, 30 years started to realize that there were other mechanisms that were at play. These are just some examples of conventional chemotherapy, and what we've started to learn is that immune therapies can actually be combined with conventional chemotherapies and have made the regimens more powerful. So as I mentioned, these immune therapies make it so that the cancer cells are no longer hidden from the immune system, and they can work well in combination. So we'll go through some examples of what these are, and it's almost a little poetic because some of, at least with the cancers that I treat, these are cancers of immune cells, and some of them even produce these antibodies that we are now harnessing, that we are now using to find the cancers, to target them, and to eradicate them. So the simplest ones are what are called monoclonal antibodies, and these are now being combined or being used in all different types of cancer therapies. Things for patients who have breast cancer, trastuzumab or Herceptin was one of the originals for patients who have lymphoma. Rituximab is one of the originals, and all different types of different classes of cancer, we're actually using these monoclonal antibodies. And so those are kind of the naked ones. We have things called checkpoint inhibitors. We'll go into a little bit more detail about those. Now combining them with things called antibody drug conjugates, for actually linking these antibodies to chemotherapy or to radioactive payloads, and things called radioimmunotherapies. We have things called bispecific antibodies. And then as far as cellular therapies, we have stem cell transplantation, CAR T cells, and really recently new approval, which are these things called tumor infiltrating lymphocytes. And this is just over the slide. We'll go into detail about all of them on subsequent slides. So the first immune therapies that we've had were antibody-based therapies. So antibodies are proteins that immune cells produce to fight things like infections, cancers, and other things. And these antibodies bind the surface of a cell, something that's expressed on the surface of a cell, something called an antigen. And so we've been able to develop our own antibodies that target something on the cancer cell and then recruit the rest of the immune system to fight it. So the antibodies look like a Y shape. They have two sets of two different chains, these things called a heavy chain and a light chain. And then the combination of the two is this antigen binding site. So that can bind to the surface of something on a cell, on a cancer cell, and then it does a whole host of things to actually kill the cancer. Sometimes it prevents the cancer's own machinery from functioning. Sometimes it brings in other proteins that will kill the cancer. Sometimes it brings in other cells that will kill the cancer. So you can think of it as kind of putting a target on the cell, and it can really bring in a number of different mechanisms to defeat it. And so this is the probably the first type of immune therapy that we had. And actually, I don't know if I can get this. So a specific type of antibody is something called a checkpoint inhibitor, and these have become used much more and more in the treatment of a lot of solid cancers. Things called pembrolizumab or Keytruda, nivolumab, ipilimumab. These are things that so I was saying a little bit earlier that the cancer cells no, you're good. We're guinea pig, right? So in order to get around the immune system, sometimes these cancer cells will show something to the immune cells, these things called checkpoints. And that will make it so that the cancer cell, or sorry, the immune cell thinks that the cancer cell is normal, and it just goes away, even though it's not. Upon discovering that these cancer cells do that, investigators designed antibodies that actually block that interaction. These things called checkpoint inhibitors. So this is an antibody, that Y shape, actually preventing this interaction between a T cell, the immune cell, and the tumor cell. And so now the T cell is recognizing this cancer cell as being a bad actor, and it'll kill it. And so this is especially useful in cancers that have a lot of mutations to them and have a lot of weirdness to them. Things like certain types of lung cancers, melanomas, non-Hodgkin's lymphoma. And so these have really changed how we treat these. And some are used alone with just the immune therapies. Some are combining two different checkpoint inhibitors. So melanomas, I can think of one where they're combining two different types of interrupting that interaction between the cancer cell and the immune cell. And then some are actually combining them with chemotherapies too, which seemed a little bit counterintuitive, but it actually, the combination of this immune therapy and the chemotherapies in certain types of cancers actually worked really well too. And this actually this discovery led to a Nobel Prize. So this was one way to unleash the immune system to attack the cancers. And it works in many, some of them better than others. As I mentioned, these antibodies can be linked to things that are what we call payloads. So the antibody can be linked to a drug. And this was an example that had been approved in multiple myeloma, but an antibody was linked to a chemotherapy. And the antibody would then find the cancer and drop that chemotherapy right there to try and not only direct it to the cancer, but then also limit the amount of side effects, because instead of it getting all throughout the body, it would go directly to where the cancer was. And then we're looking at something similarly in combination with a radioimmunotherapy, so a radioactive metal doing the same thing. So that's monoclonal antibodies and how we've used those to treat cancers in a couple of different ways. The naked antibodies, the checkpoint inhibitors, and then the ones that deliver these payloads. But we also want to figure out how to not only indiscriminately bring the immune system in, but how we can force the immune system into a certain place. And so there are a couple of different ways of doing this. You can genetically manipulate the immune system, and we'll talk about what that looks like later on. But you can actually just inject a drug that binds the cancer on one end and specifically binds the immune cells, the T cells, on the other end. So this is something that we've been using now for several years in multiple myeloma, as well as certain types of lymphomas. These are called bispecific antibodies. So what has been done is they've taken these monoclonal antibodies and done a reaction where they can actually make one arm linked to something on the myeloma cell, the cancer cell, and the other arm links to a receptor on a T cell called CD3 or T cell receptor. And what this does is it brings your T cells specifically targeted into where the myeloma cell is and forces it to recognize the cancer as foreign and kill it. And so this has been really revolutionary in the treatment of myeloma, and then they're exploring it in a lot of other cancers as well. The nice thing about this one is that, as opposed to some of the other things we'll talk about, it's a drug that's off the shelf. It's given as an injection under the skin. It is given ongoing indefinitely. And this is a number of these different treatments have been approved just in the past 3 years. So that's how we use antibody-based therapy as a type of immune therapy for the treatment of all different types of cancers. And then beyond that, we're exploring how we can take the cells themselves and either manipulate them or not, but then use them to combat the cancers too. So these are called cellular therapies. And these are therapies that generally involve the collection of cells from a patient or from a donor, sometimes manipulating them, usually through some type of genetic engineering, and then using them to treat the cancer. And so the original type of cellular therapy was actually something called allogeneic stem cell transplant or hematopoietic cell transplantation. So what an allogeneic stem cell transplant is where you have a patient who has a certain type of cancer. It's usually a certain type of blood cancer. And they have to identify a donor who is a match for them. That donor has stem cells that are collected, and then those cells that are collected are administered after some processes to the patient, to the recipient who has the cancer. Now, it used to be thought that the chemotherapy that we gave as part of this process, as part of this conditioning, was doing the whole job. But what we learned was that the donor cells create an immune response against any residual cancer. And so what that allowed us to do is not use as much chemotherapy leading into the transplant. We could actually reduce the amount of chemotherapy just so that the transplant could do most of the work, could find the cancer, and was responsible for the anti-cancer effects. And so that became kind of the initial cellular therapy. But as we've been able to go on, the years have gone on, we've been able to refine the process and make things and learn how to actually change the cells so that they are more targeted and less side effects. But there are two types of what we call stem cell transplants, and they have different roles and different indications. There's an allogeneic stem cell transplant, which I mentioned. Those stem cells come from the donor. We do something called autologous stem cell transplant as well, and these are cells that we actually remove from the patient and then give back at a later time point. The allogeneic stem cell transplant, we are using a high dose of chemotherapy to start the eradication process, but then the ongoing process of the anti-cancer effect is this donor transplantation that's taking place. In contrast to that, with an autologous stem cell transplant, the cells don't really do anything against the cancer. They're really just rescuing the patient's ability to produce blood after getting a high dose of chemotherapy. As I mentioned, the allogeneic stem cells, they have this graft versus leukemia effect. The donor cells can actually attack the leukemia and maintain a patient in remission long after they've been exposed to, or long after they've had the transplant. Whereas in autologous stem cell transplant, there is no effect of the stem cells against the cancer because it's the same patient's cells. The things that we use in allogeneic stem cell transplant on are predominantly acute leukemias, something called the myelodysplastic syndrome, and things where the bone marrow is not functioning so well. Autotransplants are used predominantly in multiple myeloma, certain types of lymphomas, and germ cell tumors. And this just is a diagram which is a little bit washed out, but essentially showing everything that we kind of went through. A donor has the stem cells removed, the patient receives some type of chemotherapy, and then goes on to receive the stem cell infusion. So that is stem cell transplant, which is kind of it's not, I wouldn't say it's unrefined, but we're not really changing anything that's done to the cells that we removed. This is a little bit different to something that we're doing a lot more of now, something called chimeric antigen receptor T cells, or CAR T cells. This is cells from the T cells that we actually collect from a patient who has a certain type of cancer. And we actually remove those cells through a process called apheresis. So the cells just come out through a catheter or spun out. They get sent off to a manufacturing facility, or a pharmaceutical manufacturing facility, where they're actually genetically engineered to put something on the surface of them that allows them to identify the cancer as being bad, as being something that's not normal. And that whole process of genetically engineering the cells takes about 4 weeks. And then we receive those cells back. And then after a light dose of chemotherapy to allow the patient to, allow the body to accept those cells, then infuse those CAR T cells back in. And so when I explain these types of things to patients, as we're kind of preparing them for it, as we're kind of outlining the next steps, it almost seems like science fiction, but we've really seen that by reprogramming T cells to be able to find these cancers, they can take cancers that would have once been thought of as incurable, and some of them have been cured. So it's really something that has sparked a lot of interest, not only in the types of cancers that I treat, which are myelomas and lymphomas, but all different types of malignancies as well. These are just some examples of the CAR T cells that are approved now, just over the past 6 years. But there are a lot that are currently in development, a lot that are under investigation in clinical trials in this area. In the same vein, there's a new type of cellular therapy that's been studied now for probably 3 or 4 decades. This is a new treatment that's been approved for melanoma, and it's got some similarities to CAR T. But instead of collecting the T cells through the blood, what they've actually done with this particular product is they take T cells from the melanoma cells themselves. They know that these T cells have already been programmed inside the body to find the melanoma and to attempt to eradicate it, but there just weren't enough. They didn't have enough of the signaling, enough of the stimulus to actually go and do it. So they extract them from these cells, or from the cancer itself, send it to a lab where it's basically trained using expanded in the lab, and then they receive a certain type of what they call a cytokine. This is a type of chemical that stimulates the cancer to, or the T cells to react, grow, and be more aggressive. And then those cells are reinfused back with more of that cytokine administered to the patient after the T cells have been infused. And so this has been something that's also been pretty revolutionary for the treatment of melanoma and being investigated for other cancers as well. So just to cover a couple of things as far as patients that I've treated and how immunotherapies were used in those treatments. So this was a younger patient of mine who had multiple myeloma. We previously did not use these monoclonal antibodies in the initial treatment of patients, but recently we found that by adding the monoclonal antibodies to their initial chemo, we've had a much stronger response. So we added the monoclonal antibody in the initial cycles. And then in myeloma, we tend to do autologous stem cell transplants. So this is not one where the stem cells themselves have an impact on the myeloma, but then we used as a maintenance treatment something that actually stimulates the immune system to continue that ongoing surveillance against the myeloma. This was an older patient who had some chronic medical issues, and her disease progressed after several lines of treatment. What actually became available around the time that her disease progressed was something called teclistamab, which was one of those bispecific antibodies where one arm binds the myeloma cells, the other arm binds the T cells within the body, brings them close, and it worked very, very well, and also had a nice balance with quality of life because she didn't require any chemotherapy. We were able to space out her treatments, and I think it was a really nice balance for her. This was another patient of mine who had relatively young from a myeloma standpoint, had several relapses. And we kind of suspected that her particular myeloma was one that would respond to immunotherapies, and she was very healthy and wanted to be as aggressive as possible. And we used that CAR T therapy where we collected her cells, sent them off to be genetically engineered, brought them back and administered them, and she did very well with that. And with that particular product, the side effects were actually pretty mild. And after that one infusion of the CAR T cells, she didn't need any other subsequent therapy as opposed to other treatments. So that's kind of the unique thing about those CAR Ts and cellular therapies. A lot of times they're one administration and then just ongoing monitoring.
Doctor, on the CAR T, how often does she have to come in for a checkup?
It's a great question. And for each doctor, it's kind of different. In the early parts, right afterward, I usually like to have them come back weekly for the first 4 to 8 weeks. As long as everything's smooth though, then I'm fine with every 4 weeks. And I've had patients out long enough that I'll see them every 2 months, where we'll just get labs intermittently. Yes.
So in this example you're doing, there's no stem cell transplant.
She didn't want the stem cell transplant.
So that was, would you have recommended that, but that was her choice not to do it?
So in general, for patients that are, oh no, she actually did go, she did have a stem cell transplant. Yeah, sorry, this was her.
Okay.
Yeah. But in general, I am recommending for patients to go through a stem cell transplant early. But it's kind of it's not a black and white type of conversation anymore. It used to be we recommended it to everybody. Now there are some patients that we don't necessarily recommend one thing or another. We kind of tell them all of the information that's out there and come up with a joint decision based on what their kind of values are related to it. One thing that's interesting is that there is actually a clinical trial that just opened where we're actually looking at CAR T cell versus transplant. Because there actually was in myeloma, there was just a recent approval using it earlier lines after when a patient progresses the first time, but actually they're trying to see can this outcompete it, and in lymphomas, in some cases, that actually was the case.
And if I could follow up, so how long was this, in this case, was there progression-free disease after the CAR T cell?
For this one here,
Yeah.
um,
Or in general?
it depends on, I mean, for this particular patient, it's ongoing in about 16 months. Or, if you look at the trials and everything, it depends on the dose that people end up receiving, as well as the, now there are 2 CAR Ts out there, so it kind of depends on which one's received. And to cut some of the other things that figure into it. But I usually tell people with this product, it's about 1 to 2 years on average, but people fall on both sides of that average. But that's, if you look at kind of the data a little bit more granularly, some have longer than that. And then on the other CAR T product, probably a little bit longer than that as well.
Well, you may have answered the question. So what year was this that she had this done?
This one was in 2021. Any other? We're to the end anyway, so I do want to thank you for all of your attention, and I'm definitely open to more questions. I think it's a really exciting area of oncology in general, and especially what I'm doing, but I think that's expanding to all aspects of oncology. We obviously have more work to do, more room to increase this so that everybody's experiencing these benefits, and definitely have to thank people that actually participated in the clinical trials as well that actually lead to these approvals.
Hey, go ahead, Eric.
Thanks, Dr. Goldsmith. Yeah, a lot of us have been in trials and been at City Hope for a long time. There's a lot of myeloma patients here, so thanks.
Yeah, I recognize a lot of things.
Just if you could give us a little more information on the radiotherapy, just where do we stand with that, particularly myeloma? I only care about us, not. Where are we in that, and what trials are going on? This data level.
Yeah, so as like the radioimmunotherapies that, so we have a clinical trial ongoing. It's in first phase, and so the data hasn't really been read out yet. So there's interest not only for us, other institutions as well are starting to look at it. The idea behind our trial is that people who have had a number of immunotherapies in the past, maybe the immune system either needs some type of added stimulus and added boost, or the immune system, the immune therapies may not be as potent later on if they've had a lot of them. So our idea was we could still use an immune therapy, one that still can stimulate the immune system, but also deliver something that we know is effective against cancer, which is this radioactive particle. But it is early, and we don't really have any.
Okay, so it's essentially the same idea, concept as an antibody drug conjugate. Only instead of the drug, you're substituting.
Exactly. Yeah, this actinium one, it is the idea behind it is that it has a lot of energy, a lot of potency, but it doesn't travel very far. So it's delivered right to the myeloma cell. It shouldn't go out into other areas. In mouse studies that looked good, but we're still trying to, see if it's effective. Yes.
Yeah, I had prostate cancer diagnosed 2.5 years ago. I had a HIFU a year ago. And I just had a biopsy and MRI saying I'm cancer-free of swelling outside my prostate. But what I want to know is, and she has had breast cancer, had a mastectomy. She's on an estrogen suppressing drug. And that's mainly all they're doing, and calcium for preventive. So I want to know for us, for preventative purposes, to minimize the chance of the cancer returning, what can we do? My urologist told me Mediterranean diet and high intensity interval training, and that's it. What about antioxidants? Are there any drugs we could take to prevent cancers? Does that even exist? Or what would you recommend in this area?
So I'll preface it by saying I don't specialize in those specific areas, and my knowledge is a little bit dated. Those recommendations I've heard other specialists do, like trying to the Mediterranean veggie diet and exercising. And exercising actually does, circling back to how it impacts the immune system, we actually do know that that leads to certain types of those cytokines, those signals that lead the immune system to be one that's a little bit more active. And so, that hasn't 100% been shown to prevent or eradicate cancer, but the steps are there, and eventually somebody's going to do a study that hopefully proves that. As far as drugs go, it kind of depends on, I think you're on the estrogen receptor blocker right now. We know that those for longer term have, decreased the risk of recurrence. And so, and that's also kind of similar to what we do, where we're using something called Revlimid as a maintenance treatment afterward. It's striking a balance between, a therapy that prolongs somebody's remission or keeps them cancer-free, hopefully forever, but one that does strike a little bit of a balance between quality of life too, because some of these other treatments, it's hard to be on them for a long period of time indefinitely. So that's a long-winded answer of saying I'm not quite sure specifically for prostate and breast as far as other things that could be done beyond what your urologist suggested. And I'd explore, go on clinicaltrials.gov or other cancer support group or focused websites and ask those questions. I mean, I don't think anybody, at least from my standpoint and my colleagues, we don't get offended when people seek other information or other opinions or clinical trials that are going on looking at how some of these things can impact somebody's life and longevity. Because ultimately this is you and your life. So if you can find, there are different institutions probably that are doing some of these later stage prevention or relapse prevention type of things, using some of the measures that you might have already alluded to. Thank you. You're welcome.
I've got a question submitted online.
Sure.
Actually, gonna switch spots with you.
Oh, sure.
I think another question's coming. Go for it.
Sure. It says, I'm on a clinical trials for retroperitoneal liposarcoma with Opdivo and Yervoy. I'm interested in your experience with and comments on whether there's anything we've seen that might be more effective. These, along with Yondelis, have produced a good response, by the way. So another preface by saying that I don't treat sarcomas, unfortunately, and have not had experience beyond some of the therapies that she's mentioned and some of the older therapies that have been out there. These two treatments that you mentioned, Opdivo and Yervoy, are both checkpoint inhibitors. So this is one of those situations where they're trying to use a combination of two treatments that take the brakes off the immune system. And at least with things like melanoma, we've had excellent responses in those combinations. So I unfortunately don't have a better answer than that for this particular question.
Another question was, did you say that CAR T effects last 1 or 2 years? What happened after?
It depends on the CAR T, depends on the patient. Some of the newer CAR Ts are looking better than that. And so on average could be more than, 3 or up to 3 years. After that, so there are other CAR T therapies that are under investigation that are targeting different things. There are other CAR T therapies that are under investigation that are, instead of being from the patient themselves, there are what we call allogeneic, so they're derived from another patient. There are the bispecific antibodies, which are effective still after when CAR T is not working. There are a number of other immune therapies and then other therapies that are not immune therapies that are either under investigation or available. And the other thing we're waiting to see now, at least in what I treat, is CAR T therapy. The indication for it has moved up to an earlier line, and so what we're waiting to see is when we've used it in this situation, does this lead to much longer time to progression, or what we might quote remissions in this patient population, and how we would sequence things after that if there's even a need.
I am CLL and I'm on immunotherapy once every 4 weeks. I also take that Z pill, I never can remember the name, for cancer. What's supposed to happen now with the immune therapy? I've been on it for about 6 months now.
Do you know which one it is?
Gamma globulin.
Gamma globulin?
Yeah.
And is this your first?
Well, I've been on it for about 6 months.
So depending on the treatment regimen that you're on for CLL, some of them will continue the immune therapy. Some of them will stop at about a year. And so, talk with your oncologist about what the treatment plan looks like. There are some that actually do discontinue at a year, and then some of them will, at least the pill will stay on indefinitely. It just depends on whatever the protocol they end up with.
I'm really stable, nothing goes up or down, I just stay the same.
Yeah.
I don't know if that's normal.
It depends on which, I'm sure they're following like specific numbers related to like the lymphocyte count, the things that the CLL count, and use that to determine what the response has been and whether they feel like things are. Yes.
For CAR T and bispecifics, are there any pre-tests that a person has to go through, like they do for the transplant, workup to see if you're able to handle it?
So it actually depends a little bit on what the insurance requires for CAR T, believe it or not. Some of them will actually want a full workup for the same that would be done for transplant. Others don't have the requirements, and so we would just use our own, whatever the institution you're getting it at would have. Generally, things like an echo, cardiogram to look at heart function, any testing. And we're generally doing things like a PET scan beforehand to see how much disease we might be dealing with, a brain MRI just as a baseline. So those types of things for CAR T. For bispecifics, there really isn't that requirement. We treat it, and other institutions might do it differently. We treat it more like kind of a more conventional immune therapy than one that is a little bit more aggressive like the CAR T might be.
Thank you.
Yes.
I just read that immunotherapy given early in the morning is much more effective than later in the day. And have you ever heard that? Or
Where did you read that?
you know what? I can't recall. I wish I would have written it down, but I said to my husband, well, that seems kind of weird, but it was like a much better response rate if you had it early in the morning.
I am not. Well, I haven't read that yet. Because it's really interesting. When you think about it, the body has this, this change based on circadian rhythm. We know that stress hormones are different at different times of the day. People are more likely to be symptomatic from some type of virus later in the day as opposed to earlier in the day.
Yeah, it was kind of along those lines, actually.
So that's very interesting. I'm going to be requesting that all my patients have morning. Sure.
Oh, so the gentleman. Do you have a question?
You talked about leveraging the graft versus disease effect with allogeneic transplants. maybe that lets you reduce the amount of chemotherapy needed for preparation. Does that have any impact on the severity or likelihood of graft versus host disease?
So it's they are two sides of this, same coin or double-edged sword, whatever word you want to use. But the graft versus tumor effect, unfortunately, is countered by graft versus host effect. So there are the T cells that develop from the donor can also attack normal organs, things like the skin, which can lead to rash, the GI tract, and the liver, just mainly because those are among the largest organs. The severity of graft versus host disease related to the amount of conditioning that people have received, I don't think there's a difference between the level of conditioning, the reduced intensity and the high dose and the high conditioning. I don't think there's a significant difference in the occurrence of graft versus host, but don't quote me on that. But from my recollection from when I was actually in training, it didn't seem to be that made a difference.
Thanks, Dr. Goldsmith, for a great presentation. It's mostly pretty clear to me, so I really appreciate it. Back to CAR T cell and bispecifics. It's my understanding if you do bispecifics, you can then do a CAR T cell, but not the other way around. Is that correct? That after a CAR T cell, you would not be able to do bispecific therapy?
No, that's not true.
You
Or that you can sequence them either way. The data that I've seen most recently is that actually doing the CAR T cell first may allow for less T cell exhaustion, and then allow for the bispecific after that. The T cell therapies, the continuous T cell therapies, may tire out the T cells, after which going to CAR T may be more challenging, but it's such small numbers and people have been successful doing it both ways. So it's hard to say unless you see it in a much bigger study. There's just some suggestion based on small numbers and small studies.
I did see one more hand up here. Go for it, and then we'll end there.
Just wanted to follow up with BlenRep and antibody drug conjugates. Given that one had its problems and kind of aren't using it anymore, are there other drugs with the same method of action coming along, or will we're kind of giving up on that approach?
It's actually across all cancers probably the highest number of recent early phase there are a lot of antibody drug conjugates being developed across all cancers, across all malignancies. When it comes to myeloma itself, there were data for BlenRep that looked positive. They were positive large studies, and I know there's a lot of debate out there about whether it should be put back on the market, because I think for the right person, the right patient, it might actually be useful. We still try and get it on a compassionate use basis from time to time. But I can think of at least one other antibody drug conjugate that is being developed, something that is targeting BCMA, but using a different type of payload. And there are a couple of places looking at these radioimmunotherapies as well. And we're starting to look at CS1 as a different target for myeloma also with the payload. So I don't think that it's dead. It's just got to find, and with the change in how CAR T is going to be used, it may open up opportunities for what comes after if there needs to be.
Can we have a round of applause for Dr. Gabriel? For an excellent guinea pig that responded well to our treatment. Thank you very much. Relatively smooth. Thank you all so much for doing this. Anyone first time visiting us tonight? Okay, wonderful. I'm gonna just make sure you get our first time visitor form before you leave. We have a workshop evaluation on your feet. I've got pens I can pass around if you need them. If you could please take the time to fill that out. So would you mind grabbing those pens right behind you? And then there's extra evaluations for you all as well. So feel free, we can pass around this cup of pens. For those of you joining online, thank you so much. I'll be emailing you the same workshop evaluation form. So thank you so much for joining us, and you're welcome to sign off now. For those of